Welcome back to BIOMEDPREP, the channel where we simplify complex medical concepts and help you prepare smarter for exams and clinical practice. Today's video covers high-yield clinical cases and visual diagnoses that frequently appear in medical school exams, OSCEs, and board-style questions. We'll walk through real clinical presentations, break down how to recognize them quickly, and understand the underlying pathology so you don't just memorize, you truly understand. Make sure you stay until the end, because these are exactly the types of cases that separate average students from top performers. Let's get started with an emergency presentation. A 19-year-old male is brought to the emergency department with confusion and difficulty waking up. He reports a severe generalized headache, neck stiffness, and muscle aches. His temperature is 39 degrees Celsius, and on examination, he has a petechial rash across his thorax and extremities. When his neck is flexed, his knees involuntarily bend. This is a positive Brudzinski sign, indicating meningeal irritation. So what is the diagnosis? This is meningococcal meningitis, a rapidly progressive and potentially fatal infection. The causative organism is Neisseria meningitidis, which is a gram-negative diplococcus. It spreads through respiratory droplets or direct contact with infected secretions, meaning outbreaks often occur in crowded environments like dormitories. Why is this case important? Because meningococcal meningitis can lead to septic shock, disseminated intravascular coagulation, Waterhouse-Friderichsen syndrome. Early recognition saves lives. Exam tip: if you see fever plus neck stiffness plus altered mental status plus petechial rash, think meningococcal meningitis immediately. Now let's move to a classic genetic disorder. The images demonstrate three hallmark signs: Steinberg sign, where the thumb protrudes beyond the hand; Walker-Murdoch sign, where fingers overlap around the wrist; arachnodactyly, meaning long, slender fingers. Diagnosis: Marfan syndrome. This is a connective tissue disorder caused by mutations in the FBN1 gene, affecting fibrillin-1. Patients are typically tall with long limbs, hypermobile joints, and cardiovascular complications. Months later, this patient develops severe tearing chest pain radiating to the back. What does this suggest? Aortic dissection, a life-threatening complication caused by weakening of the aortic wall. This is why Marfan patients require routine cardiac monitoring. Now let's discuss signs of aortic regurgitation, which often accompanies aortic root dilation. Corrigan's pulse, a bounding, collapsing pulse. De Musset's sign, rhythmic head bobbing. Quincke's sign, capillary pulsations in the nail beds. Clinical pearl. Always think cardiovascular complications first in Marfan patients. They are the leading cause of mortality. A 65-year-old man presents with progressive shortness of breath and fatigue. On examination, you hear a diastolic decrescendo murmur and notice bounding pulses and head bobbing. Diagnosis: aortic regurgitation. The gold standard investigation is an echocardiogram, which allows visualization of valve incompetence and blood flow. Peripheral signs you may see include Corrigan's sign, carotid pulsation; Muller's sign, uvular pulsation; de Rosa's sign, femoral murmur; Traube's sign, pistol shot sounds. In developing countries, the most common cause is rheumatic heart disease. Exam tip: if the question mentions wide pulse pressure plus bounding pulse, think aortic regurgitation. You perform a urinalysis and find 3+ protein, with everything else negative. This strongly suggests significant proteinuria, often pointing toward glomerular disease. Possible causes include nephrotic syndrome, systemic lupus erythematosus, multiple myeloma, HIV-associated nephropathy, diabetic nephropathy. Next steps should focus on identifying the cause. Important investigations include 24-hour urine protein, renal function tests, HbA1c, HIV testing, ANA and complement levels, lipid profile, protein electrophoresis, renal ultrasound, renal biopsy, light bulb clinical insight. Proteinuria is never something to ignore. It often signals serious kidney pathology. This image shows onychomycosis, a fungal infection of the nails. Typical features include nail discoloration, thickening, separation from the nail bed. The most common causative organisms are dermatophytes, such as Trichophyton rubrum, Trichophyton mentagrophytes. Treatment options include terbinafine or itraconazole. Remember, topical treatments are usually ineffective for severe disease. Oral therapy is often required. Here we see spoon-shaped nails, known as koilonychia. Diagnosis: iron deficiency anemia. Other signs include brittle hair, angular stomatitis, atrophic glossitis. Common causes: gastrointestinal bleeding, hookworm infestation, menorrhagia, chronic disease or malnutrition. Diagnostic tests include iron studies, full blood count, endoscopic evaluation if GI bleeding is suspected. Exam tip: nail changes often reveal systemic disease. Always look at the hands. A 22-year-old female presents with hair loss, fatigue, joint pain, and hand lesions. You suspect a diffuse connective tissue disease. Examples include rheumatoid arthritis, systemic sclerosis, polymyositis, dermatomyositis, Sjogren's syndrome, but the most likely diagnosis here is systemic lupus erythematosus. The hand lesions are likely vasculitic lesions, reflecting immune-mediated vascular inflammation. SLE is a multisystem disease. It can affect the skin, joints, kidneys, brain, and heart. Clinical pearl: when a young woman presents with multisystem symptoms, always consider lupus. The chest X-ray shows a classic cannonball appearance. This refers to multiple, well-defined round nodules scattered throughout the lungs, most commonly caused by pulmonary metastases from cancers such as breast, thyroid, renal cell carcinoma, colorectal cancer, prostate cancer. Further investigation should include CT scan of the chest, bronchoscopy. Exam tip: multiple lung nodules usually mean metastasis, not primary lung cancer. To diagnose rheumatoid arthritis, we use criteria that include joint involvement, positive serology, RF and anti-CCP, elevated inflammatory markers, symptom duration. RA is not just a joint disease, it has extra-articular manifestations. Eye complications include scleritis, episcleritis, keratoconjunctivitis sicca. Now remember Felty's syndrome, which is defined by the triad of rheumatoid arthritis, splenomegaly, neutropenia. Clinical insight: always think systemically. Autoimmune diseases rarely affect just one organ. That brings us to the end of today's high-yield clinical review. If you found this helpful, make sure to like the video, subscribe to BIOMEDPREP, and share it with classmates who want to study smarter, not harder. Let me know in the comments what topics you want covered next. Until next time, keep learning, stay consistent, and good luck with your exams.